I want to talk today about intracardiac shunts. I will talk about left to right shunts as well as right to left shunts. First, what is a significant right O2 step up that is diagnostic of left to right shunt? You need to know that simple number, which is 8%. This is on screening oximetry that we do in every single right heart cath we do, regardless of the indication. We sample the high SVC and the PA, and an 8% step up between the SVC and the PA is considered a significant shunt. Now, when you do have 8%, always make sure that the PA catheter is not too deep and wedged or partially wedged, in which case the PA sat will be falsely elevated. So when you have 8%, always verify that you're not having an error in your PA measurement. Now, 8% is not a perfect number. You could have an 8% step up and not have a significant shunt. And conversely, you can have a significant shunt with less than 8%. And I will elaborate on that. But that's a good number to start with. Now, once you have an 8% step up on this oximetry screen, then you can do full screen of all the cardiac chambers, including the low SVC, IVC, multiple RA samples, especially lateral RA sample, RV and bilateral PA. And this way you can localize where the step up is. And wherever your step up is, usually this is where your shunt is, although your shunt could be a little bit downstream from the step up, because sometimes that shunt streams a little upward. For example, here we have a step up between the high SVC and the low SVC. The shunt could be at this level, at that SVC level, which could be sinus venosus ASD, but it could also be sinus secundum ASD with a streaming of that shunt a little bit upward. So keep that in mind. You could have a step up at the RA level. However, the shunt could be a VSD. For example, you could have a VSD with a step up here and some tricuspid regurgitation that streams into the RA, and you happen to be sampling that stream. So keep that in mind. Another caveat when you do full oximetry run is the right atrium. The right atrium is the least accurate oximetry sample, simply because depending where you put the catheter in the right atrium, you might be capturing the coronary sinus stream, which is very hypoxic, and you may be capturing an area that is not getting a good mixture of all the IVC, SVC, and coronary sinus blood. So you may be capturing an area with a preferential stream for any of those three sources. So you may get a lot of variability in getting the right atrial sample. So be careful if you see that the right atrium is more hypoxic than the rest with a step up at the ventricular level. That doesn't necessarily mean that you have a shunt at the ventricular level. It could be that you're having a poor RA sample that is excessively hypoxic from the coronary sinus. So this is regarding the left to right shunt. Now, how to tell if you have a right to left shunt? Right to left shunt is diagnosed hypothetically if you have a 5% step down between the pulmonary venous O2 and the systemic arterial oxygenation, the aortic oxygenation. I will explain how to do that hypothetically, but it's practically very difficult to do. Practically speaking, if the arterial O2 saturation is over 95% on room air, this rules out significant right to left shunt. And in this case, you assume that whatever arterial O2 sat you have is the same as the pulmonary vein O2 sat. Those two numbers here are the same. Now, if your arterial sat is less than 95%, of course, that doesn't mean you have a right to left shunt. Overwhelmingly, it means that your patient has either lung disease or sedation, hypoventilation, obesity, pulmonary edema, but you have to think of right to left shunt and rule it out. If you have arterial O2 sat over 95%, you rule out right to left shunt. Right to left shunt is initially presumed present in the case of arterial O2 sat less than 95% that does not resolve with O2 therapy, especially a couple of liters of oxygen and with taking a few deep breaths. So if you have an intracardiac right to left shunt, the systemic oxygenation is not going to improve by giving the patient oxygen, because in this case, the oxygen supply to the lungs is already fine, and you can't improve it much with oxygen therapy. The problem is shunt at the cardiac level, and you cannot improve that with oxygen therapy, hypothetically. In this case, we consider the pulmonary venous O2 normal or near normal. We plug in a 98% number, and the arterial O2 sat, we consider it whatever it is measured. So we consider there is a step down between PvO2, 98%, and the arterial O2 saturation. However, if arterial saturation quickly improves with oxygenation or deep breath, then there is no right to left shunt, and pulmonary venous O2 is considered equal to the desaturated arterial O2 sat. And if the hypoxemia is not profound, we prefer to do our study without oxygen, particularly when the arterial oxygenation is over 85, 90%. We prefer to do our study without oxygen, as I will explain later. Now, regarding that lack of improvement with oxygen, that's the theory. On occasion, patients with right to left shunt may improve with oxygen therapy. The reason is if you have a right to left shunt with pulmonary hypertension, when you give oxygen, oxygen is a pulmonary vasodilator. So it will improve pulmonary hypertension, and therefore it will improve the right-sided flow and will reduce the right to left shunt. So you may get some improvement of oxygenation when you give oxygen to right to left shunt, but it won't be quick and it will require a lot of oxygen. Now, how can we prove right to left shunt hypothetically? Hypothetically, if you want to truly prove right to left shunt, you have to catheterize all the pulmonary veins, all 4 pulmonary veins, average what's the oxygen saturation from all those 4 pulmonary veins, and see if there is a 5% step down between the pulmonary veins and the arterial or aortic sat. This is practically very difficult to sample all those veins. In patients who have a defect like an ASD, it's easy to sample the left upper pulmonary vein, but it's hard to sample all 4 pulmonary veins. Now, you could sample the left upper pulmonary vein. However, let's say the left upper pulmonary vein is 98% and the arterial saturation is 92%. That doesn't necessarily mean that there is a shunt, a right to left shunt, because remember, it could still be lung disease or hypoventilation, and the patient is having pulmonary venous O2 98 and arterial O2 92%. The reason being that lung disease is typically mosaic and heterogeneous. So the oxygenation in different lung quadrants and different pulmonary veins may be different. So you may be sampling the best pulmonary vein. So having 98% in the left upper pulmonary vein, that doesn't mean that the O2 saturation in the other vein is that high. It could be 90% in the other veins. So much, if you only sample one vein, you may be sampling the best one, and you may get a false impression of a step down. So yes, to diagnose a right to left shunt, you may sample the easy left upper pulmonary vein, but that may give you a false diagnosis. Ideally, you have to sample all 4 pulmonary veins. And some people have used the wedge saturation to obtain pulmonary vein blood. So you wedge your catheter in all 4 pulmonary quadrants and you get 4 wedge sats and you average those. Again, the problem is that wedge sat is not a perfect correlate of pulmonary venous. saturation because it depends how well you're wedging your catheter. So again, practically, it's very difficult to diagnose right to left shunt by catheterization. So for somebody who has an arterial O2 saturation less than 95%, we frequently get asked, do they have a right to left shunt? The answer to the referring doctor is there is no simple catheter diagnosis of right to left shunt. The diagnosis of right to left shunt relies on the clinical picture. For example, PAH inherently causes secondary right to left shunt. PAH with hypoxemia is frequently and almost inherently associated with pop-off right to left shunt, as I will explain later, and rely on how easily that arterial O2 saturation improves with O2 therapy. Okay, so we diagnose in the cath lab left to right shunt, not directly right to left shunt, which is more clinical picture and clinical maneuvers. There are three main forms of right to left shunt in adults, and the clinical context, such as those, will help distinguish them. I will elaborate on those a little bit later. I will move on now to focus on the left to right shunt and the left to right shunt calculations. Anytime we're thinking of shunts, you need to have that image in your mind. This is the image of mixed venous O2, pulmonary arterial O2, pulmonary venous O2, and systemic arterial O2. This is the systemic side of the circulation, SaO2 and mixed venous O2, and this is the pulmonic side of the circulation. When you have left to right shunt, you will have a step up between that mixed venous O2 and the pulmonary arterial O2. You will have a step up, like I said, of 8%. Normally, the mixed venous O2 approximate the PaO2, and actually the best mixed venous O2 in a normal individual without shunt is the PaO2, where blood achieves its best mixing of IVC, SVC, and coronary sinus flow in the PA. So PaO2 is the best mixed venous O2, but when you have a shunt, then your mixed venous O2 becomes the oxygen saturation of the chamber upstream of the shunt. And I preferably take the patient most upstream. So I prefer to use, in cases of shunt, the SVCO2 or the average SVC and IVCO2, meaning 3 SVC plus 1 IVC divided by 4. Okay? You could use the chamber immediately upstream of the shunt. The problem, like I explained, the chamber immediately upstream of the shunt can get streaming retrogradely from the shunt, or if it is the right atrial chamber in the case of ASD, right atrium is very subject to error in sampling. And you have to best sample it at the lateral RA side. I prefer to use either SVCO2 or 3 SVC plus 1 IVC divided by 4 as my mixed venous O2 for the step up and especially for the QPQS calculations. So we have the mixed venous O2 and we will have a step up between this and the PaO2 in the case of left to right shunt. And in the overwhelming majority of the cases that we do, we have a pure left to right shunt. So the pulmonary venous O2 is typically equal to the arterial O2, even if they are hypoxic. It's usually hypoxia from, like I said, sedation, hypoventilation, lung disease. You need to keep this picture in your mind because that will illustrate how we calculate QP and QS. And again, as I explained, PVO2 is equal to arterial O2 sat if no right to left shunt, that is arterial sat more than 95% or arterial sat less than 95, but corrects quickly with oxygen and with a few deep breaths. Now, how to calculate QP and QS? It's very important. That's one of the most important calculations you need to know in hemodynamics. And you need to know how to calculate the absolute QP and QS. And you actually need to calculate the absolute QP and QS in every shunt case beside calculating the ratio. So to calculate QP and QS, we use the Fick equation. QS means the systemic cardiac output. Okay, it's the output between this and that. This is the systemic output. The inflow of that systemic flow is the arterial sat. The outflow is the mixed venous O2, the SVC O2. Normally, the systemic flow QS and QP are equal, but in the case of shunt, this is where the pulmonic flow will be higher than the systemic flow. And this is what this ratio is the pulmonic flow divided by the systemic flow. One thing I want you to remember from this talk, when we have shunt, do not use the term cardiac output. You have two cardiac outputs. You have systemic output, which is QS, and pulmonic flow, which is QP. So whenever we're talking shunt, specify systemic output, QS, or QP. Do not use the word CO, cardiac output. It doesn't exist anymore. So to calculate the systemic flow QS, we use the Fick equation. It's O2 consumption divided by the arterial O2 content minus the mixed venous O2 content, which is 1.36 by hemoglobin by arterial O2 saturation minus mixed venous O2 saturation. And you multiply this by 10 to get the units appropriate. Because if you don't multiply by 10, this is milliliter O2 by deciliter, since hemoglobin is a gram per deciliter. So you multiply by 10 to get the O2 content in milliliter of O2 per liter of blood. So to get the units straight. So this is a QS. QP is the similar equation. It's actually O2 supply by the lungs divided by the same thing. Pulmonary venous O2 minus pulmonary arterial O2 content. The O2 supply by the lung is equal to whatever the body is consumes. So the O2 consumption in QS is equal to the O2 supply by the lungs. Here the lungs supply O2 and raise the pulmonary venous O2 from that pulmonary arterial O2. So for the QP, we use O2 supply divided by pulmonary venous O2 content minus pulmonary arterial O2 content. Now, when we do QP-QS ratio, those denominators will flip. So when we do QP-QS ratio, it's actually the systemic sats divided by the pulmonic sats. So it's arterial O2 sat minus mixed venous O2, meaning the SVC-O2 or the chambers before the shunt, divided by pulmonary venous O2 minus pulmonary arterial O2. So QP-QS ratio is systemic sat divided by pulmonic sats. And we call it significant shunt when it's over 1.5. This is moderate shunt. And large shunt when it's over 2. But 1.5 already qualifies for surgery or intervention. In this particular illustration that I've given here, if you calculate the shunt ratio, it is a systemic sat, so 96% minus 70% divided by the pulmonic sats, which is this one here, pulmonary venous O2, which is 96% as well, since there is no right to left shunt. So 96% minus 84%. So 96 minus 71% divided by 96 minus 84% equal 2.1. So this is a sinus venosus ASD or secondum ASD with a 2.1 QP-QS ratio. And those pulmonic side and systemic side of the circulation are the same when we're trying to measure vascular resistance. So when you're measuring pulmonary vascular resistance, we use as outflow the pulmonary venous pressure and as inflow the pulmonary arterial pressure. And for SVR, it's as inflow the arterial pressure and the systemic venous pressure. Now, after seeing the detail, again, you need to know how to calculate that in detail. But there is a quick way of calculating it in your brain. Anytime you see significant step up, you can calculate the QP-QS in your brain. Since overwhelmingly PvO2 is equal to SaO2, the calculation is frequently, you take that arterial sat, which let's say is 96% in a particular patient. It's 96% minus the lowest O2 sat in the right-sided chamber divided by 96 minus the highest. So you have a step up of 70 to 80%. The QPQS is 96 minus 70 divided by 96 minus 80. So that's a quick way of calculating QPQS. Now, these are some summary ideas for mixed venous O2. It is best to use SVCO2 or 3 SVC plus 1 IVC divided by 4 for your calculation. On a full oximetry run, you may use a chamber just upstream of the shunt as mixed venous O2, but there is a chance that some of the shunted blood has streamed into it. I prefer to use the proximal most chamber SVC and the distal most PA for this calculation. There are some caveats to all those calculations and assessment. Caveat 1, significant step up may be more or less than 8%. So that 8% is not stone cold number. Let me give you this example. Let's say this patient has a 31% SVC SAT and 44% PA or 2 SAT. Does he have a significant shunt? You have a 13% step up. But if you calculate the QPQS, it's 96 minus 31 divided by 96 minus 44, and it's about 1.3. It's not a significant shunt. Maybe he has a shunt, but it's not a significant shunt. The idea with the 8% that we're picking up is that we're trying to capture significant shunt. We're not trying to capture insignificant, hemodynamically insignificant shunt. Well, this is a case where 13% translates into a hemodynamically insignificant shunt. Conversely, take the other way around. If you have somebody with a mixed venous O2 of 80% and he has a step up of 5% into the PA, well, do the math here. 96 minus 80 divided by 96 minus 85, it amounts to 1.5. So this patient only has a 5% step up, yet his QPQS translate into significant QPQS. So 5% was a significant step up in him. So here's the idea. The lower your cardiac output and the lower your mixed venous systemic O2 saturation, the higher the step up that is needed for the shunt to be significant. So the lower your cardiac output, the lower that mixed venous O2 is before the step up, the more step up you need for the shunt to be significant. Conversely, the higher that mixed venous O2, especially when it's high in a patient with a high systemic output, the higher that mixed venous O2, meaning the higher the systemic cardiac output, the lower the step up that is needed for the shunt to be significant. And in general, that 8% is more applicable for the 60s, 70s% mixed venous O2. So know those caveats. And this has to do with the oxygen hemoglobin dissociation curve. When the mixed venous O2 SAT is low, reflecting a low cardiac output, okay, when the mixed venous SAT is low, any little bit of increase in O2 content or volume via the left to right shunt will cause O2 saturation to have a big jump when you're on that steep portion of that hemoglobin dissociation. So the O2 SAT will go very abruptly with any shunted volume when you're very hypoxic in that systemic venous SAT. Whereas if your systemic venous SAT is high, you need more O2 volume shunted, more O2 content shunted to get a step up in O2 saturation. That is why really the true definition of shunt is to use absolute shunt flow or O2 content of the shunted blood in milliliter per liter, in milliliter of oxygen per liter of blood, not the O2 SAT, which is not just affected by the shunt volume, but also by the hemoglobin O2 dissociation curve. However, that's the easy way of screening for shunt. And the best way is to just screen it using 8% and calculate it quickly in your brain, that QPQS quickly, and see if it amounts to any significant shunt. Another caveat in QPQS measurement is you really need to do your measurements simultaneously. That's why I like to sample the PA and the SVC simultaneously. I sample the high SVC from the sheath and the PA from the catheter tip simultaneously. When you do them non-simultaneously, even a few minutes difference in sampling can create instantaneous variability in the O2 saturation. If the patient wakes up in those couple of minutes, if the patient gets upset, anxious, more pain, more awake, that can change the systemic O2 consumption. That will create an illusion of shunt if you're sampling two different chambers at two different times. So I like to sample the SVC and PA simultaneously. When you do full oximetry run, you can get a couple percent it changes as you're sampling multiple chambers that are just due to physiology. Okay? So samples should be collected in a steady state within a few minutes, preferably on pullback when you're doing a full oximetry run, and expect some variability in measurement between chambers aside from the shunt itself. I want to give a case. This is a 70-year-old female who had a late inferior MI presentation 4 days ago. And she has a ventricular septal rupture on echo with left heart failure clinically. And this is on right heart cath, her measurement. This is the SVC SAT, 39%, PA SAT, 80%, and systemic SAT is 95%. So what is the QPQS? Clearly, there is a big left to right shunt. And honestly, even if that arterial SAT here, I would have expected to be late 80%. It wouldn't really imply a right to left shunt. This is a patient with ventricular septal rupture. You expect her to have pulmonary edema and hypoxemia. So even if it is 88, 85%, that doesn't mean in this context, take the context, it doesn't mean right to left shunt. Most likely the pulmonary venous O2 is the same as the arterial O2. So there is a significant left to right shunt, and the QPQS here is this number, whatever it is, here 95 minus 39 divided by 95 minus 80, okay? And this amounts to a QPQS of 3.7. We placed a balloon pump on this patient, and this is what happened after placing a balloon pump. Her mixed venous O2 went up from 39 to 56%. The PA SAT remains practically unchanged at 78%. Now, if you calculate the QPQS, it's evidently less. There is less step up. So what happened? What did the balloon pump do? The balloon pump did two things in this patient. One, it improved the forward left-sided flow. When it improved the forward left-sided flow, that means it improved the QS. That QS here has improved. Therefore, when the QS improved, the mixed venous O2 improved. So that's the first thing it did. It improved the mixed venous O2 before the shunt, so from 39 to 56%. The second thing it did by improving the left flow, it reduced the left to right shunt. That's why the step up is less. QP to QS has declined. So it did two things: improve systemic flow and reduce systemic to right-sided flow. So increase the QS and reduced QP. Now, another caveat, the third caveat of this shunt calculation is being on oxygen. That's an important thing to understand. Simple shunt calculations using this equation, the QPQS equation, and using the standard Fick equation, whether the QPQS, the simplified ratio, or whether the absolute calculation, is inaccurate in case of oxygen therapy, especially oxygen therapy that raises systemic saturation to close to 100%, since in that case, there is an increased fraction of free oxygen, especially in the pulmonary vein where O2 concentration is the highest. So actually, oxygen content is no longer just 1.36 by hemoglobin by saturation of oxygen in the particular chamber. you have to add the fraction of the dissolved oxygen in the plasma. So the calculation becomes more complex. You need to use the true Fick equation, which integrates here. There is a plus dissolved oxygen, which is usually meaningless, but it comes more meaningful in the pulmonary veins when you're giving oxygen and you're oversaturating that pulmonary vein way over 100%. That's one explanation why oxygen makes the math inaccurate. But this is the explanation I prefer. This one here, the second explanation. Mixed venous O2 is the lowest O2 saturation. You're getting a shunted blood, and the patient is on oxygen. So that oxygen will raise the O2 content of the shunted blood. And since mixed venous O2 is the lowest, and it's on the steepest portion of the O2 hemoglobin dissociation curve, it will rise dramatically with any increase in O2 content, such as giving the patient oxygen. So it will be the one to rise most dramatically when you're giving the patient oxygen. So it will cause the step up to rise dramatically, more than you will raise the systemic arterial sat, which is on a flatter portion of the hemoglobin O2 dissociation curve. So giving oxygen will raise arterial sat, but will more dramatically raise the O2 step up. So mixed venous O2 being the lowest O2 saturation past the shunt, meaning the PA saturation, will be exaggerated the most with oxygen therapy that gets shunted. The PA sat will be the one to rise the most with oxygen therapy, which makes the denominator drop, which will make the QPQS rise dramatically. Okay, so O2 step up and QPQS will be exaggerated in a patient receiving oxygen, especially if you are inducing O2 sat over 90 to 95%. Meaning, if the patient is really hypoxic, 80%, and you give him oxygen, it's okay. You're probably not going to exaggerate the O2 step up and the QPQS too much, simply because your arterial O2 saturation, which is also your pulmonary venous O2 saturation, is also on a steep portion of the O2 hemoglobin dissociation curve, so that the pulmonary venous O2 may rise somewhat similarly to the pulmonary arterial O2, and the denominator may not change much here, and the QPQS may not change much. Also, the mixed venous O2 saturation will rise with the increase of the systemic O2 content and the rise of the SaO2, and it may rise almost as much as the post-shunt PaO2, so that the step up will not be exaggerated, and the whole equation eventually may not be exaggerated for the QPQS calculation. So the bottom line is this: if the patient needs oxygen to have his SAT to 90%, it's fine. Give him as little as needed to keep his SAT 90%. But don't give him more than needed. Keep his SATs around 90% for your measurement, not more. Don't try to normalize arterial oxygenation, because that will damage your measurement. And that same idea applies to when you're trying to measure cardiac output by Fick in patients without a shunt. Oxygen, giving the patient oxygen will exaggerate the calculation of Fick cardiac output for those two explanations, unless you use the true Fick equation integrating the dissolved O2 oxygen. So I will move on to the caveat number 4, how to calculate PVR in patients with left to right shunt. Can anybody tell me? What's the equation for PVR? So as a reminder, PVR in general is calculated as mean PA pressure minus LA pressure divided by cardiac output. But whenever we talk shunt, do not use the term cardiac output anymore. So please, one thing I want you to remember from this talk: when we have shunt, do not use the term cardiac output. Cardiac output does not exist anymore. You have two cardiac outputs. You have systemic output, which is QS, and pulmonic flow, which is QP. So there is no cardiac output. So whenever We're talking shunt, specify systemic output, QS or QP. Do not use the word CO, cardiac output. It doesn't exist anymore. So in order to calculate PVR in shunt, it's mean PA minus LA pressure divided by QP, the pulmonic flow. And QP should be used, and it should be calculated by Fick equation. That's the only way you can get QP. Do not use QS, and certainly do not use the thermodilution cardiac output, which is inaccurate in shunt. And you calculate QP using this equation, O2 supply divided by this. The ideal way of calculating a Fick is to do the true Fick, meaning measure true O2 consumption by making the patient wear a hood and measure the actual O2 consumption. This is rarely done in any lab in the US. We use the assumed equation, which plugs in here, for example, one of the equation, 125 milliliter per minute per meter square of body surface area. We use that assumed Fick equation, but that's fine. That's the only way it can be done in most cath lab in the US, but do not use thermodilution cardiac output. Here is what thermodilution cardiac output. Thermodilution cardiac output, it will be an attempt to assess QP. Okay, so if you use thermodilution, at least say I'm doing thermodilution QP. However, it's inaccurately assessing that QP for two reasons. Whatever cold injectate you're injecting, it's going to go in the right chamber, then recirculate. So you're not going to have a straight curve. You will have a bumpy curve. You will have a curve, then you will get left to right shunt, then left to right shunt. It will be a bumpy curve, elongated curve. So it will make the QP look smaller than it truly is because you're elongating that curve. So it's an underestimation of the true QP, and it's an overestimation of the true QS. It's somewhere between QP and QS. So it's inaccurate for either. Do not use it. Another thing that can happen with thermodilution, if you have a very large left to right shunt with very large QP-QS ratio, that large left to right shunt will create such a huge stream that will immediately warm your injectate, so much so that you don't even get the thermodilution curve, because that cold injectate, it's basically diluted. So you get a flat curve, and the techs start thinking, what's going on? What is wrong? What is wrong is that you have a shunt. So on occasion, when you have a big QP-QS and you see flat thermodilution curve, that in a way inherently confirms you have a large left to right shunt. So always calculate those. And by the way, like I said, in all shunt studies, you don't just calculate QP-QS ratio, you calculate absolute QS and absolute QP. Report those. You need to, because you need to report the cardiac output, the systemic output, and the pulmonic one for calculation of PVR and SVR and systemic output. The fifth caveat I want you to know, the QP-QS ratio is a net shunt ratio. If somebody has a QP-QS of over 1.5, I said it's a significant left to right shunt. However, you could have a QP-QS ratio of 1.2 and still have a large left to right shunt. How? In case of bidirectional shunt. Very important. So the patient may have large left to right and right to left shunt, bidirectional shunt, with hypoxemia and pulmonary hypertension, but a small QP-QS ratio as the ratio assesses the net shunting into the predominant direction. For example, you have a huge left to right and a huge right to left shunt, but the left to right is a little higher than the right to left, so you end up with a QP-QS of 1.2. That doesn't mean that the left to right shunt is small, it's just the net difference is small. So in that case, the QP-QS underestimates the severity of shunting, which may be better assessed by the calculation of the absolute left to right and right to left shunt. There is a way of calculating absolute shunt, and this is adding another Q here called the Q effective. I will explain it at the very end, and I have it explained in my book as well. So you can calculate the absolute shunts in that case to assess the true severity of shunts. But just know this idea first. So the QPQS is a net shunt fraction. If patient is hypoxemic with suspected right to left shunt, QPQS more than 1 means the shunt is bidirectional with a net left to right shunt. A net shunt of 1.3 may still signify a very large shunt volume, in this case, potentially with severe pulmonary hypertension. Shunt ratio does not tell the whole story in this case. You must calculate absolute left to right and right to left shunts. Imagine, for example, the case of a common atrium, where blood freely mixes between the right and left chambers. There is such congenital condition. The right to left and left to right shunt are both very large, yet QP equal QS. You can also imagine the single ventricle phenomena in infants. Same thing. You have mixing of the right and left chambers. You have a single ventricle, yet QP-QS ratio is 1. This illustrates the limitation of QP-QS ratio in bidirectional shunting and the importance in that case of using just looking at the degree of step up and step down. The degree of step up and step down will be significant even if the QP-QS ratio may not be in those cases, and also measure the absolute shunt flow using a third component here called the Q effective, which I can explain later. Let me talk here a little bit about right to left shunt again. I explained how to diagnose right to left shunt earlier, but I want to explain the types of right to left shunt we encounter in practice and how to diagnose them in practice. So we are often asked the question about, does the patient have right to left shunt in two settings? Somebody who has a pulmonary arterial hypertension on echo and cath and he's hypoxemic. Another setting we are often asked about is somebody with unexplained hypoxemia and who has a normal PA and RA pressure, but hypoxemia without a clear explanation. Those are the two common settings. So let me answer the first one, hypoxemia in PAH. Hypoxemia in PAH, this is the answer. It's a clinical answer. It is usually caused by a right to left shunt. That is a secondary pop-off mechanism at two levels. So when somebody has hypoxemia with PAH and the doctor is asking you, can you diagnose to me right to left shunt? The answer should be twofold. One, we cannot really directly answer it by our right heart catheterization. So we're not going to give you a direct answer. Number two, well, you should expect inherently, clinically, a right to left shunt, because inherently severe PAH gets a pop-off compensatory right to left shunt at two levels. PFO, which about 25% of the population has, when you get a rise in RA pressure, it opens that PFO and leads to a secondary right to left shunt. That is a compensatory shunt. That is unloading that right ventricle and reducing right ventricular failure. And you can get also AV shunting at the pulmonary level through re-recruited fetal AV anastomosis. Normally, neonates have pulmonary arteriovenous connection between the pulmonary arteries and the pulmonary venous circulation, those involute on birth. But even normal humans continue to have maybe up to 2% degree of AV shunting and AV communication. This AV shunting and AV communication will increase in the case of PAH when the pulmonary microvascular flow is plugged. This will create a diversion, a pop-off from that plugged pulmonary microvascular flow. So you will get inherently arteriovenous shunting at the pulmonary level and at the PFO level as a pop-up mechanism for pulmonary arterial pressure and for RV failure. Number two, right to left shunt is often good in PAH. It alleviates right heart failure and it increases left filling and output. That's why atrial septostomy remains an end-stage treatment for refractory PAH. So let me give you that scenario. A patient with severe PAH has right to left shunt on bubble study and hypoxemia. Again, like I explained, inherently, that's just a pop-off mechanism and it's a compensatory right to left shunt. Could it be that this is a shunt that was originally left to right and that caused severe PAH? Could it be that case? It's possible, but overwhelmingly, this shunt is not Eisenmenger, it's just a compensatory PFO shunt. To think that this shunt was left to right and caused PAH and then eventually caused reversal of the shunt and Eisenmenger, you really need to have those three ideas. One, you need to have extreme shunting. To think of shunt having caused the PAH and reversed, you need to have extreme shunting with resting or exertional cyanosis. You need to have a large visible shunt on imaging, not just positive bubble or small SD. It will be a huge stream. And in adults with shunt-induced PAH, the shunt usually does not become purely right to left, and there will be usually some like left to right shunt as well. It will be bidirectional shunt. It's rare to diagnose an adult with shunt-induced Eisenmenger at such a late stage where it's purely right to left shunt. So, in those patients, the only adults who will get Eisenmenger are usually large ASD or occasionally moderate VSD that causes hemodynamic compromise late in age. Most VSD that are large will cause hemodynamic compromise and Eisenmenger at a young age in infancy or childhood. So the VSD diagnosed at an older age is a moderate VSD or VSD that got bigger with time, or it's an Eisenmenger for an ASD, which is rare. So even in those cases, you're likely to diagnose the patient before he reaches that full reversal of shunt to a right to left. So that's why looking for left to right and ruling out left to right shunt inherently will rule out shunt as a cause of pulmonary hypertension in those patients. Okay, so I hope you understood those ideas. And here I want you, as an extrapolation on that Eisenmenger and shunt-induced PAH, which, like I said, is uncommon. It's an uncommon cause of PAH in adults. I want you to know the 4 stages of PAH in patient with left to right shunt. Those are the 4 stages. We most commonly see PH with left to right shunt, such as ASD. The first 2 are the most commonly seen. We rarely see the last 2. But those are the 4 stages that you need to know. When you have a left to right shunt, such as ASD in an adult, you get flow-induced PH with normal PVR initially. Since the pressure is approximately equal to flow multiplied by PVR, if you have an increased flow, you will get an increased PA pressure. So that's the first thing you get. Anybody with ASD will get a little bit of increased PA pressure from increased flow. That's the most benign. They will have normal PVR. Number 2, with time, you start having remodeling of the pulmonary artery and you get reversible mild PAH. So we'll get a rise in PVR, which remains though less than 1/3 of SVR and less than 5 Wood units. Those patients can still be closed based on the guidelines. Then later on with time, you get the irreversible PAH, where PVR becomes more than 2/3 of SVR or more than 5 Wood units. In this case, closure is contraindicated in both the ACC and ESC guidelines. If the PVR is in between, like PVR between 1/3 and 2/3, or maybe if the PVR is barely above 5 Wood units based on the ESC, you can consider giving the patient vasodilator therapy and re-evaluating his PVR. Look for PVR decline and a rise of QPQS ratio to more than 1.5, meaning you want to see the PVR decline and have a QPQS predominant left to right shunt that is very predominant with a ratio over 1.5 to consider those patients for closure. Okay, but here we're getting into the irreversible PH. Then you get Eisenmenger. The term Eisenmenger is an extreme form of irreversible PH, where your PVR is not only more than 2/3 of SVR, it's more than SVR, period. It's not only more than 5 Wood units, it's more than the all of the SVR. And the shunt reversed to a predominant or exclusive right to left shunt, meaning your QPQS becomes less than 1 now because you're predominantly right to left shunt or you're fully right to left shunt. And importantly, in the ESC guidelines, they clearly state when you have somebody with pulmonary arterial hypertension and you find a right to left shunt, even if you find a small anatomical defect with precapillary PAH, small defect such as VSD less than 1 centimeter or ASD less than 2 centimeter. 2 centimeter is not too little, but even ASD less than 2 centimeter does not usually account for PVR elevation. When found in a patient with PAH, those defects are incidental and potentially with pop-off right to left shunt mechanism and should not be closed. And this is what they state: marked elevation in PVR in the presence of small cardiac defect, which themselves do not account for the development of elevated PVR. The clinical picture is very similar to idiopathic PAH. Closing the defect is contraindicated. So I mentioned that there are 3 forms of right to left shunt in an adult. I explained the most common one, which is PAH or RV failure with compensatory right to left shunt at a benign PFO level, or at the pulmonary level, a pop-off mechanism. Now there is a second one, which I explained as well, which is Eisenmenger, very rarely diagnosed in an adult with no prior congenital history. And it's rare to diagnose a patient at this stage with a pure right to left shunt and with a true Eisenmenger. You're more likely to diagnose a patient with shunt, left to right shunt, and pulmonary hypertension at the stage 1 and 2, maybe 3. It's rare to be purely Eisenmenger diagnosed in an adult. This is the second form of right to left shunt you may encounter. And this is the third form that's not common, but we think about it and we get asked about it a lot. You have a patient with no pulmonary arterial hypertension. He has a simple PFO with normal RA pressure, but with cardiac anatomy that favors the right to left shunt streaming and hypoxemia with exertion or with upright position, what we call the platypnea orthodeoxia syndrome. So it's a normal individual, no PAH. He has unexplained hypoxemia, no bad lung disease, no bad heart disease, normal RA pressure, but you find a PFO. Could that benign simple PFO be causing right to left shunt? Particularly, you think about it when hypoxemia happens with exertion or with upright position, the platypnea orthodeoxia syndrome. And it can happen. And when can it happen that a simple benign PFO with normal hemodynamics causes a right to left shunt? It can happen. One proposed mechanism for right to left shunt across a benign PFO with normal RA pressure is interatrial septal anatomical distortion and a change in the septal relationship to the inferior vena cava, resulting in streaming of the IVC blood through the septal defect. IVC flow goes normally posteriorly and superiorly. So if you modify the interatrial septum anatomy in a way that you put it straight into that stream of the IVC flow, you may get a right to left shunt despite a normal RA pressure that is slightly lower than LA pressure, but not dramatically lower. You're not going to get that shunt across a benign PFO in a patient with an LA pressure of 25. It has to be that RA and LA are not dramatically different. RA lower than LA, but not dramatically lower. Okay? And those are 2 papers of case series of such patients who have no other explanation for hypoxemia and normal hemodynamics. They closed the PFO and hypoxemia improved. This is a patient series from Toronto, 52 patients with all of whom received a PFO closure, and all of them improved their arterial O2 oxygenation from 81 to 96%. But in both cases, they confirmed that the shunt is due to the PFO. In this Toronto paper, they sampled all 4 pulmonary veins using wedge sats, and they proved the step down between the pulmonary venous saturation and the systemic saturation. In this paper, they confirmed the shunt by the fact that arterial saturation did not improve while breathing 100% oxygen or barely improved. This is how they proved that this hypoxemia was due to a right to left shunt, and the only explanation was in those adults with benign hemodynamics was a PFO. and they close them, they improve. But this is a rare situation. You have to think about it when there are conditions that will result in streaming of that IVC flow into the PFO straight. So there are precipitating conditions in these patients that can result in horizontal distortion of the heart, the RA, and the interatrial septum. So anything that distorts the septum horizontally or also tilts it posteriorly, horizontally or posteriorly, puts it in the stream of the IVC flow. So in those papers, there is an observation that the interatrial septum was frequently displaced toward the horizontal position so that the atrial defect was placed directly in line with the blood flow from the IVC at its entrance to the RA. This change in the axis of the atrial septum may be secondary to dilatation of the proximal ascending aorta. When the aorta, which sits over that interatrial septum, dilates, it can push that septum down and make it horizontal. This is phenomena exaggerated with age or with the existence of an aortic aneurysm. Similar tilting of the heart favoring right to left shunt may be observed after a pneumonectomy or abdominal surgery. So, for example, if you remove, not in this X-ray, but if you remove that right lung, the heart may be pulled this way and the interatrial septum may become more horizontal. That's why this phenomena of platypnea orthodeoxia has been well described in patients after right pneumonectomy classically. So you get that streaming of IVC to RA. The key word in this process is streaming. And in that Toronto registry, these are some of the triggers for that. So most commonly there is a trigger. Sometimes there isn't any, but most commonly there is, especially post-pneumonectomy, post-lung transplant, any lung pathology, again, that changes that septal anatomy. That's why that condition may be diagnosed in an adult who did fine all his life, and all of a sudden in his 60s, he's starting to have shunting through a PFO that he had all his life. Aortic dilatation, aortic surgery, even sometimes weight changes that changes the abdominal anatomy and the abdominal pressure on the heart, and again changes that configuration of the interatrial septum. So right to left shunt across a PFO may occur in the setting of normal right-sided cardiac pressures when congenital or acquired distortion of the cardiopulmonary anatomy alter the geometric relationship between the interatrial septum and vena cava blood flow, resulting in preferential streaming of deoxygenated venous blood across the PFO. This physiology is often accentuated in the upright position as the accompanying decline in right atrial filling pressures causes additional tension on the interatrial septum, making it more horizontal. So standing up may pull down that interatrial septum and create more streaming, which causes that platypnea orthodeoxia syndrome. So I hope you understood those three forms of right to left shunt in the adult. The most common one, PAH with compensatory right to left shunt. Less common, very uncommon, Eisenmenger or irreversible PAH with a changing of the shunt to right to left or bidirectional shunt. And the third one is the keyword, the right to left shunt streaming across a simple PFO. Uncommon, but you may think about it in patients with severe refractory hypoxemia that doesn't improve with oxygen, particularly when it is positional or exertional, but not improving with oxygen supply. There is a fourth right to left shunt, which is AV malformation with no PAH. That's AV shunting at the lung level, such as in cirrhosis. All right, so this is a case. I'm giving you those saturation. The SVC sat is 39%. The PA sat is 54%. The arterial O2 saturation is 92% and did not dramatically change with being on oxygen. So calculate here the QPQS. This is a patient who has a big left to right shunt, right? You have a big step up. And you're thinking with his big left to right shunt, is having some PAH, look at that, pulmonary arterial pressure, and maybe he's having some reversal of shunt. So it fits that this arterial saturation is due to some right to left shunt. So in that case, what do you call pulmonary venous O2 for your calculation? So in those cases, one, if you have an ASD or PFO, you can try to sample the pulmonary vein. But like I said, you're going to sample one vein. Ideally, you sample the four. But that's fine. In those cases, you can sample one. Since you know the issue is a shunt, not a lung disease, you can sample one and measure the step down. Number two, since we don't often do that, you can assume the pulmonary venous O2 is 98%. That's what we use for our measurement. Assume 98%, as long as the patient doesn't have bad lung disease, okay? So QPQS becomes 92 minus 39 divided by 98 minus 54. And the QPQS comes up as 1.2. So it doesn't seem bad, right? 1.2. How come you have a massive O2 step up, yet QPQS is only 1.2? Why? This case shows you the downside of QPQS. QPQS is a net shunt fraction. If the patient is hypoxemic with suspected right to left shunt, QPQS more than 1 means the shunt is bidirectional with a net left to right shunt. So it's measuring the net shunt. You may have a huge left to right shunt and a huge right to left shunt, but the net is not much different. Okay? So shunt ratio does not tell you the whole story in this case. How do you calculate the severity of the shunt in each side? You need to measure absolute left to right and right to left shunt in those cases. And here we go again to the Fick equation, which is O2 consumption divided by hemoglobin by 1.36 by, in the pulmonic circulation, PVO2 minus PaO2 by 10, okay? Now, another downside of Fick is that, ideally you need to use a hood and measure the true O2 consumption. The Fick we use has two pitfalls. One, we use simplified Fick. We don't add the dissolved O2, which is not a problem unless you're on high flow O2, like I explained. Number two, we use an assumption of the O2 consumption. We just say, you're this tall and big, this is how much you're consuming at rest. That's changes with age and sex and your wakefulness, so it's not accurate, but that's what we use in most labs. Anyway, we will make that assumption and we'll calculate our absolute QP in this case and our absolute QS. Then, if you do want to measure, if you do want to assess the severity of the shunt in those cases, there are two ways of assessing the severity of the shunt. Not QPQS. Again, QPQS tells you where is the net shunt. Is predominantly left to right or right to left. That's all QPQS tells you. It's predominantly left to right in this case, 1.2 ratio. But if you want to tell, well, how is it severe or not in each direction, use the degree of step up and step down. So here, 39 to 54, that's way more than 8%. It must be severe left to right shunt. 98 to 92%, it's more than 5% on the left side, step down. So just using the O2 saturations can give you an idea about the size of the shunt in each direction. Now, if you want to be more perfect, you can do something called Q effective. I don't ask you to know that, but it is in all textbooks. And I want you to have an idea about it. That's more advanced. So you measure the absolute QP, as we explained, absolute QS using the absolute Fick equation. Then you measure something called the Q effective. Q effective means what's the cardiac output, assuming there is absolutely no shunt. No right to left, no left to right shunt. In this case, there is no step up. So the PaO2 is equal to MvO2, and there is no step down. So SaO2 is equal to PvO2. So you apply the Fick equation as if there is no step up. So you use here the 39% as your mixed venous O2. So use 39 because that will be your PaO2 as well in that case. And you use 98% as your SaO2. Okay. So use 98%, the no step down systemic saturation, and 39%, the no step up systemic venous saturation. And that's where we come up with 98 minus 39%. And we come up with 2.8 liters per minute. Then you measure the differences, okay? 3.8 minus 2.8, that's your shunt, 1 liter. The cutoff when you use this is 25%. So it's definitely significant left to right shunt. So this patient has bidirectional shunts and probably significant both sides. And he has severe pulmonary arterial hypertension, okay? And if you calculate the PVR, it's 55 minus 18, PA, mean PA minus LA, divided by QP. And it comes out as 10 Wood units. So this patient, we're really concerned he's having irreversible PAH. Maybe not quite Eisenmenger. His PVR is not bigger than SVR yet, and he's not purely right to left shunt, but we're really concerned he's Eisenmenger phase, okay? Anyway, we gave him nitric oxide. European guidelines recommended trying chronic pulmonary vasodilator therapy in some patient with PVR that is elevated, but not that elevated. PVR 1/3 to 2/3. Okay, PVR 1/3 to 2/3 or more than 5 units, but not more than 2/3 of the SVR. So this is not guideline, what he did. This is not guideline applicable. But anyway, we did it in this case with an PVR that is 10 Wood units. So we did this, and here is what happened. Analyze those numbers. One, the mixed venous saturation went up. Your step up went up dramatically. Okay, so it went up from 39 to 48, but more importantly, the PA sat went up dramatically. What does this tell you that the PA sat went up dramatically? What does this suggest? So what happened, the step up went up dramatically, which means your left to right shunt went up dramatically because your right to left shunt went down dramatically. So that right to left shunt reversed, and now it's much more left to right shunt. So another thing you notice is the arterial O2 saturation went up to 100%. So you no longer have right to left shunt. So giving a pulmonary nitric oxide, a pulmonary vasodilator, reverse that shunt. It's purely left to right shunt now with a massive O2 step up on the right and no O2 step down at all on the left. So no right to left shunt anymore. That's great. That suggests that that shunt is reversible. That's not Eisenmenger. Even though the initial PVR of 10 suggested it, that vasodilator study suggested it's not. So with NO, PVR dramatically declines, which sucks more flow in the right circulation, thereby sharply increasing the left to right flow and abolishing the right to left flow. Hence, arterial O2 saturation normalizes. You have no longer right to left shunt. This change in shunt flow can only be explained by a dramatic reduction of PVR. Right-sided O2 step up is much more pronounced, and now the QPQS is equal to 3. The absolute QP evidently goes up. PVR goes down on your calculation. Okay, if you plug the QP and you do what we explained, the mean PA minus wedge pressure divided by that much higher QP, you end up with a much slower PVR, okay? Notice PA pressure didn't change. Why? Because I always explain PA is a composite of two things, of PVR and flow. Here we drop PVR dramatically, but we increased as a result the shunt flow dramatically. Therefore, the PA number didn't change, but its component changed. So here that was helpful. It showed that that PVR dramatically resolved. We can reverse the shunt. Maybe he will benefit from shunt occlusion. Of course, you need to put that patient on chronic vasodilator and prove that this reduction is sustained in a chronic basis before considering closure of a shunt. And I showed this again. Eisenmenger is a late form of irreversible PAH, and PVR is higher than SVR. And those are, please know, the 4 stages of PAH and left to right shunt. When we see ASD in an adult, or occasionally moderate VSD that's causing PAH in an adult, we often see those
flow-induced pH, usually mild with normal PVR, or with mildly increased PVR, less than 1/3 of SVR. In the guidelines, you have ASD with pulmonary hypertension, but PVR less than 1/3 of SVR and less than 5 Wood units, close it. If you have PVR over 2/3 of SVR or more than 5 Wood units, that's irreversible PH, avoid closure. Although both guidelines allow chronic vasodilator treatment and redoing the study for PVR in the medium range, 1/3 to 2/3, slightly above 5 Wood units. Then you redo your study and you try to prove shunt reversal, becoming purely left to right shunt with a QPQS more than 1.5, and show the PVR decline to less than 1/3 SVR. Eisenmenger is an extreme form of irreversible PH. PVR is more than SVR. You have absolutely no reversibility with vasodilator treatment.